Respected seniors, colleagues, and fraternity, good afternoon to you all. For this session, which is on Screen Right to Save Site, the Smart Community Ophthalmic Screening Methodology. So this is a talk regarding this, in which we actually want to focus upon the documentation part of community screening, which have been largely lacking. So for this talk, we have Honorable Professor Samanta sir, who will be introducing the topic to all. Dr. Rashmi Kumari from AIMS Devgar, Assistant Professor in Department of Ophthalmology, Dr. Mrinal Singh, Senior Resident from Department of Ophthalmology, AIMS Devgar, and myself, Dr. Abhishek Onkar, Associate Professor in the Department of Ophthalmology from AIMS Devgar. So without further ado, I will just call upon the stage Professor Samanta sir to start with his talk.
Thank you, Professor Onkar, as well as the participants of this instruction course. At the very beginning, I like to say one or two lines. If we like to do any sort of work, any sort of service, the first requirement is need assessment. Is it necessary to do this work? Then the magnitude of necessity, how much is necessary. After having this need assessment, we can proceed to find out the ways how we can do this need assessment. And after getting some baseline data from our need assessment study, which is being done by screening procedure, we can plan how to implement our services to the community in need. That is the very basic words of community ophthalmology, what I am practicing for the last 44 years. And as a part of the Association of Community Ophthalmologists of India, as a student of community ophthalmology from the International Center for Eye Health, London, as well as a government ophthalmologist serving at the mobile eye unit attached with Bankura Medical College for long 17 years as its senior surgeon, and afterwards as a faculty member of so many medical colleges in West Bengal as well as in Chhattisgarh. This is my core idea that need assessment is the premium part of any service. And need assessment always requires a beautiful screening procedure. To start with my deliberation as an introduction of this beautiful smart technique for ophthalmic diseases in the community, I just like to tell you some interesting part of my life. Long back, about 40 years back in the year 1984, what I experienced as a young ophthalmologist like Professor Onkar when I was posted as senior ophthalmic surgeon and in charge of mobile eye unit of Bankura Medical College, which was meant for the 7 southern districts of West Bengal. Once I got the message and direction from Government of India to go to a district in Purulia to go on with a door-to-door survey of one community in search of eye diseases. In those days, what I will say in my presentation, that what was the traditional method and what change we like to make it through smart technology, it was nothing but door-to-door visit and recording of the eye diseases. So we got the message from Government of India that you will have to go to a village known as Begun Kodar in Purulia's district, which is at the border of Jhalda and Purulia, that is of Jharkhand and Bengal. Begun Kodar district you will have to go and have to screen those patients. This sort of selection of villages and this instruction from Government of India were being given a computer analysis and computer detection method. The computer has selected these villages all over India, and those are the ideal villages where we should go on for door-to-door survey and should take this data and others. But now the whole system is changed by the smart technique and others. What the recent RAB survey done by Professor Praveen Vasisht has done, this is totally different because of the beautiful experience what I got. On reaching the headquarters of Purulia district, when we asked the chief medical officer, sir, we like to go to Begunkodar village for survey. We are coming from Bankura Medical College. So they are going on, yes, Begunkodar, yes, it's near the Jhalda border like this and near. So you please go to Jhalda and try to find out the village Begunkodar. So we went to Jhalda. Then reaching Jhalda, the sub-divisional health officer told, oh sir, that village is already devastated by flood. No person is there, no villager is there. You just see, going from Bankura to that Begunkodar 300 kilometers with my big team. In return, there is no villager, no presence of that particular village. So that was the fun. But there, all those has wiped out. And so we have come with this particular session, what we like to have this, that why screen differently for ophthalmic disease in the community. I have got no financial disclosure in this presentation. So community ophthalmic screening methodology, what I have told, that is a part of the need assessment study towards a service-oriented formula to do something towards our national program for control of blindness. So it includes documentation, active patient participation, accurate clinical data management, and referral in tribal setting, and leveraging technology and portable devices. You always know, and you should always remember, that screening without service is of no good. Going to a village, find out 2 or 3 cataract patients, you are documenting. The second question of that particular blind person, sir, you have documented, I have got cataract, it requires surgery. So what next? Where should I go? How can I get the treatment? If you say, I do not know, then they will not allow you to go into the other doors. That's why you should be always ready with the service part also, and you have to direct that particular person what would be the next service to them. And that's why this particular technique, what we like to present before you, and what design of this instruction course has been done by Professor Onkar, is known as SMART. Very correctly, it's a social engaging. We have to include all the parts of the society in this. In this context, I like to tell about a beautiful part of our community eye health practice. In the year 1995, we have made one beautiful Raniband model in Bankura, what has been published in those days in the weekly bulletin of the School of Tropical Medicine, Liverpool, London. In that, we engaged some villagers only up to the education of class 8, and they have been trained in the nearby Bharat Sevashram Sangh, and where they have been asked to go door to door to identify the blinds and to motivate them to the nearby health center for some services. And that is social engaging. Second, it should be manageable. Money, manpower, and mentality is the part of the community of ophthalmology. So every part of our practice should be manageable with these 3 sources. We must have got enough resources, enough manpower, as well as mentality of the people. It should be achievable. It should be practical. It should be reliable, and over and above, in this 3rd decade of 21st century, it should be technically enabled. Now, we just like to give a bird's eye view what was there and what should be there. The traditional eye screening method, and what through the smart technology, what we like to do. In smart traditional method, we usually made manual door-to-door visit with manual documentation, direct examination of the eyes, and as well as visual acuity test, eye pressure, and physical examination. You'll be surprised to know, with a piece of rope we used to send our community eye health workers, maybe a village volunteer or some ASA worker, to each and every door to door, and they asked all the family members to come on the courtyard, and we asked them to count the fingers at a distance of 3 meters. In that way, very crudely we like to find out how many of them are visually handicapped, so far as without any spectacle examination or operation or anything like that. So those people have been taken to a nearby screening center where we like to have the spec test and others. But nowadays, it's all digitalized. It's all digitalized collection of this, our information storing and manageable health structure. It should be accessible. We should go not to door like all those days of traditional by person to person, but it is all based by our digital methods, and it is flexible, accessible, and allowing for remote monitoring and use of telemedicine technologies. And the data management. In those days, it was all manual. We're coming up to our base camp, and every night we like to go on with all these permutation, combination, and compilation. But nowadays, those days have gone with the plain and paper. But it is all digitalized with data management and real-time updates and data analysis. Efficiency. In those days, these volunteers with 3-4 days orientation, or the health workers with 7 days orientation, has been sent to the field for door-to-door visit and others. But nowadays, it is all technically oriented, and it is all being oriented by our automation, remote monitoring, and data-driven decision. But above all, cost. This door-to-door data collection was very much cost-effective, very much expensive, and it was not feasible in those days. But nowadays, with this initial setup cost, the startup is a bit costly, but afterwards it is very much manageable. That can give rise to a cost saving and improve resource allocation. And above all, it gives a preventive care. But only one thing, this machine can give everything without very personal communication, with very personal attachment and very personal cure or resuscitation and relief and reassurance, what this particular traditional system can give by this way. And above all this can be done with integrating with our healthcare system, where there will be a personal touch as well as a digitalized method of screening system. And that can only give rise to a more holistic approach to patient's care. Thank you very much, and we are sure that this instruction course will be very much acceptable to all of you, and you will also try at your own place with this particular method, smart method. Thank you very much.
Thank you, sir, for this resounding introduction to our course. Next, I would like to invite Dr. Rashmi Kumari for a talk on mainly smart uses of diabetic retinopathy for social and community outreach programs.
Dr. So good evening all. I will be, after such a night's introduction, you must be now aware of what we are talking about, the smart screening. So my talk will be restricted to DR to HDR, that is diabetic retinopathy to hypertensive retinopathy, on-spot screening to telereferral for retinopathies. I will be showing some digital devices as a part of my presentation, but I have no financial interest to declare. So nowadays, non-communicable diseases like diabetes and hypertension are talk of the town and are health hazards or health epidemics of this 21st century globally. So why are we bothered about? Besides being life-threatening, they are sight-threatening also. These retinopathies can make a patient devoid of their sight. So DR, that is diabetic retinopathy, is a major cause of blindness in working middle-aged population and is the 5th cause of blindness globally. So statistically, to overview this data, from 2021, when the prevalence was 537 million, it's estimated to rise to 643 million in 2030, and in 2045, it's going to rise up to 783 millions. And our being a developing country, it has been said that 3 out of 4 adults with diabetes live in developing countries, that is low to middle income countries. So coming to our statistics, India accounts for 1 in 7 of all adults living with diabetes in the world. I am talking about diabetes, but diabetes and hypertension generally coexist. And in fact, hypertension is one of the risk factors for diabetes. So that's why we have taken both the retinopathies together. So 1 in 2 adults living with diabetes are undiagnosed. This is our problem. And soon, India will be going to the global capital of diabetes. So what is the solution? We have to, because diabetes and hypertensive retinopathy are preventable. How? If they are screened, diagnosed, and treated at time. So now the screening procedure should be affordable, accessible, and accurate also. So as our job, what we used to do, besides providing services in a tertiary eye care center, we frequently conduct camps at peripheral centers. And this is our team. We have a retina specialist with his helpers and nursing officers. And he is doing the most reliable and gold standard procedure for detection of diabetes. So is it cheap? Yes, the instrument is cheap, but we can afford retina specialist going to every peripheral centers. We don't have a retina specialist even at every tertiary center. So how can we afford retina specialist visiting each and every PHC or CHC? So this is the problem. Halanki, this is the gold standard procedure, doing indirect ophthalmoscopy and on-the-spot screening. But we have a shortage. 1 ophthalmologist per 1 lakh population. So this is not going to solve the burden of disease which I mentioned about. So what should we do? We have to engage our healthcare professionals to help us out, to fill this void. How is this possible? As Sir said, digital devices. So this is the most useful digital devices for capturing images of retina. This is called a fundus camera, and it has gone its under evolution being standard, wide field, or stereoscopic. And besides taking images, what other advantages do we get? It has helped us in documentation. It has helped us in counseling of the patient. The patient can see their images and they will be more convinced. Monitoring of retinopathy. So it has been found to be very sensitive and specific also. So it has led to a development of another branch, that is teleophthalmology, where the pictures are captured by non-ophthalmologists and analyzed by ophthalmologists. So what are the barriers now? Ours is a rural-based country. Patients are ignorant, and it's not a point of time. Diabetes is a chronic disease, and we need regular, repeated screening. So there are some technical challenges also. Can you see the design of this fundus camera? It's not portable at all. We need to have some training of the staffs because it needs some alignment of the optics part. We need to have a constant electricity supply and an internet coverage for all of these. So again, and this equipment is quite costly. Again, a cost factor, which is important for our setting. So we need to be a smart worker. Like this crow has smartly taken what it wants to, and this gentleman has added wheels to its burden. So what should we do? So there has been, as the needs develop, the development goes in that direction so as to overcome those barriers, and one of these is modifications of designs. To overcome these hefty designs, there has been modifications and designs of fundus camera to make it portable. And there are various modalities available, and they differ in image quality, field of view, whether they require mydriasis or not, and the nature of images. And the development has went afar, and we have now get handheld fundus cameras also, and they have proven to be high sensitive and specific, and the sensitivity progressively increases as the disease increases from NPDR to PDR, very well serving our purpose. And there is provision of instantly uploading the images to cloud-based, very well serving the purpose of documentation also. So, And the recent addition into this series is a relatively new, useful clinical tool to image the fundus, that is smartphone-based fundus cameras. It has many more additional advantages, like it's portable, it's chargeable, it's inexpensive relatively, it's lightweight, it can be handled, it can be non-mydriatic or mydriatic, there is sufficient field of vision, there are autofocus feature of smartphone can be incorporated for getting high image quality, and the light source uses very low intensity as compared to the fundus cameras, which increases the compliance of the patients. So the advantages are manifold. So literally, it can be done by anyone. As Sir said, socially engaging. If we are lacking of health professional, we can even engage the community of persons to take pictures from this type of cameras. So it's very engaging, and it's relatively very easy to learn. So there are articles which supports its feasibility and clinical utility, and there has been studies to compare the image qualities with gold standard conventional tabletop fundus cameras, and it has been found to be highly sensitive and specific method of screening. Validations has also been done for the smartphone-based retinal photography. Now, what is the problem now? Again, image has to be analyzed by an ophthalmologist. So this is again the limiting factor in this technology. So it can result in delayed interpretation, delay in proceedings for the management of sight-threatening diabetic retinopathy. So here comes the role of artificial intelligence. Why are we supposed to be intelligent? Because we can analyze, think, categorize, and we can decide. So incorporating artificial intelligence is similar to training a computer to take decisions. How is this done? This is done by feeding thousands of images to this computer, developing algorithm either in the form of robots or softwares, and they are just giving decisions also. So there is a subset in artificial intelligence called machine learning, where the machine automatically learns with its experience, and this we can harness in form of decision making. So different DR analysis algorithms are available which work on image enhancement, the identification of interest region, then descriptor computation, and then DR classification. So this has definitely bridged the gap where we were lacking the graders or retina specialists or ophthalmologists. So this is doing the work on our behalf. Definitely we have to check it, but this can cut short our labor to a great extent. So we have also tried this smart screening at our center. So this is a handheld camera, and we are just trying to take images out of this. This time we don't allow the retina specialist to go to the camp, and this is being done by our residents with the help of hospital staffs. This is how the image of the retina is captured, and then it is analyzed with a software which is inbuilt, and it can indicate whether it's referable or you have to get under monitoring. Referable by diabetes mellitus means severe to moderate to severe NPDR to PDR with any amount of macular edema, that is sight threatening. So if we want to print a report, it can instantly give a report also. We can give the report to the patient, and simultaneously he or she can be referred to a retina specialist. So this, by seeing the reports, the patient gets motivated also, and it's very useful for counseling part. So advantages are manifolds. It has increased awareness of diabetes and early referral, and ophthalmologists or retina specialists can give more chair time to the referable diabetic retinopathy. It can prevent complications, obviously, and it's a skill. So every skill is important. It is giving job opportunities to the society as well. So it has also been validated in different studies, and there is a published report that traditional healthcare system, while can serve one ophthalmologist, can serve 4,000 persons per year. With integration of artificial intelligence, it increases tenfold. That is, one ophthalmologist can cater to 40,000 population. So it's remarkable. So to conclude, effective screening is desirable method, and fundus photography along with telemedicine can enable faster real-time screening, and portable digital imaging devices with integrated AI-based automated algorithms appear promising and can potentially reduce the burden on human graders. Thank you so much.
Thank you, ma'am, for that illuminating talk. And like ma'am mentioned, many of those imaging were taken actually by the technicians and by the residents using only a 90D initially, 90D and a smartphone base and a video call of WhatsApp. So that is what we were trying to do. And finally, these portable cameras definitely helped a lot. So next, coming to the next talk, that is the basic part, that is the documentation. How to screen and document, that is what we start with, vision. So how are we in the camps? Like in hospitals, HMIS already exists, but in the outreach programs, the documentation part is largely lacking. So that is what this talk is going to be about. So, we'll just try to unravel it in terms of these 6 who's and why's on this topic. So as sir already mentioned, the smart technique, by what we mean is a socially engaging, manageable, archivable, reliable and tech enabled. So this talk is mainly, the first part will be dealing mainly with the documentation of the epidemiological data in community settings and vision screening and its documentation using the smart methodology that we have been trying to propagate. So data, so first thing is data. Without data, you cannot move ahead. In today's time, data is gold, data is oil. We already have been hearing those sayings. So traditionally, like till now, what are the forms of documentation that we use in community settings are mainly registers, maybe Excel sheets, somehow registers remain the backbone. That is how we document in the camp settings mostly. But HMIS apps do exist and they are being used but very sparsely. So that is like our main target area, and we will just try to elucidate how it can be used. So this again, as I sir already said in his those lucid stories, like once you come back from the camps, you have to spend the whole night documenting and gathering the data. So that obviously is a headache. Though reliable, we have had excellent data from those registers, and that is what has been our backbone of our community ophthalmology. But yes, now we have some tech enability, so why not use it? So that was the traditional thing that was being used. And advantages of digital documentation, I think that is all well known to it, and sir already mentioned it regarding the documentation, archivability and retrieval, and for like analysis part. So you do not have to like bother about retrieving the data. The app can actually do the analysis part as well and give you very wonderful pie charts and bar diagrams and all that, right? So as I said, in hospital settings, this transition has already been smooth. They already exist. But in community settings, it has largely been lacking. Some talks, like in the community ophthalmology free paper session, I heard that like people are using it. But like again, as I said, very sparsely and very limited settings. Okay. So how are we supposed to do that? So HMIS mobile apps that are like one of the keys, and using a QR based enabled registry. And like I am from a government setup, and where we actually are using a CDAC model, and which has a HMIS integration, and we are now moving on to a mobile based QR based Ayushman Bharat health account linked data, so that you get that centralized data and you can utilize it actually for any analysis purpose. So how that can be done is, so as I said, now patients are like very skeptical about using a QR or scanning a QR. Now in today's time, smartphones are not an issue. Like electricity ports may be an issue. You cannot find in rural settings, electricity is an issue, but not smartphones at all. People are like well versed with smartphones, so that is not a limitation at all in today's time. So with a QR, with a like a government backup, that this is a government QR, so people do have some trust in that, and they actually do scan those QRs. So what we do in this is, yes. So the patient just scans that QR and gets an OTP, it gets linked, and all the whatever the data, epidemiological data is there, that is being captured through his already existing Aadhaar or whatever data he wants to share. So that is up to the patient, but yes, you have that epidemiological data once and all for all. And what secondly it does, it creates a token system. So you can have some queue management even in the camps. So the patient knows, okay, mera jo queue hai 13 number pe, so I have to wait so much of time. So that solves a bit of the like management issues also. Okay. So, and yes, if it can go further. Now this is like under trial only, but yes, patient can self-register themselves. So you can actually, if you are planning for a huge camp, so like 2 hour slot you can keep in the morning, patient can self-register, get a token generated, and you can have that queue management again, right? So that is the workflow for the patient and for doctors, how they can proceed with it. Now, what I said was retrievable and analyzable data. So it gives you wonderful analysis, whatever you want. So in this, we are location wise, so temporally, geographically, geospatially, you get all those data. So if you can, if there's like in COVID times, if you want to know, okay, patients, what allergic conjunctivitis are coming from which zone and which is like more prone to that region, so that you can have very well mapped. So, and also disease-wise graphs can be mapped. So this one is like for individual specialities, but we can have it mapped even for diseases. So those bar diagrams can be in the form of like what is for allergic conjunctivitis, what is for cataract, what is for glaucoma. So you get all that data, so you do not have to spend time and your brain over that. The app will actually be providing you that. That can be a good research tool as well. So as I said, geospatial mapping, and from region and disease wise, you can get those data very easily. So, and like for epidemics, that is like a very wonderful tools to recognize those hotspots, and you can target them. And even like for a certain disease, like if you get to see, okay, diabetic retinopathy is zone se zyada aa raha hai. So you can put your efforts towards that zone accordingly and channel your resources accordingly. So now coming to the second part of this, that was the data documentation for the screening, for the outreach purposes. Second part is like the vision screening. So how do we document it? So we definitely do a vision screening. As sir said, 3 meters rope leke hum karte the, and we used to document. So that is still handy and definitely the backbone again. But we can modify it, and this is like one thing that we have been doing since last October, World Sight Day. So this is the app, which is a WHO app they came up with, and this is a wonderful tool. So we have been doing with since October with all our camps, be it school camps, be it rural camps, be it diabetic retinopathy, be it glaucoma screening. So we use only this app, but yes, we are also parallelly doing a comparative study with the traditional vision documentation. It's a very simple app using the mobile. So all the instructions are actually in the app. Once you click it, anyone can do it. It's like what ma'am said, ABCD, anyone can do it. So long distance, short distance, you can record it, and it engages the patient actually. So they are like very actively doing it. So distance are like 2 meters required for the distance, and near 40 centimeter distance you can do it. Full illumination, e-tumbling charts will be there, and that has got like a bracketing effect also, like in perimetry. So if the patient stops, says, okay, I'm not able to decipher what that line is. So actually it will go back to 2 steps further, again come back to 2 steps down, and finally reach a threshold. Okay, so this is your visual acuity. So the chances of error are actually very low with this modality. So this is like our 3rd year MBBS students. We have been like, they just introduced the app to them and they were like very interested. Yes sir, we will be doing that. And so we did it in the camps. These were some CRPF personnel for the presbyopic screening. So in presbyopia, actually, they do it themselves. So that is very engaging. So they find it very interesting, and they cooperate very well. So be it rural children, women, or any now schools. So these are our nursing officers and residents. So simultaneously, they have the mobile, distance are set, and they are able to do that very easily. So this is what the results will come out like. For a normal person and for an impaired vision. And this has got like a lot of significance. That is what I have seen, especially in the schools. So when you tell the parents, okay, आपके बच्चे का vision 6/12 है, आपको जांच करा लेना चाहिए. They want actually hear to you most of the time. They said they will be in a denial mode initially कि नहीं आँख ठीक है, वो तो सब कुछ देख रहा है. But once you give it in percentages, so like parents are skeptical about percentages. Nowadays, anything below 90%, below 80%, they will know something is wrong. So once you start depicting them in percentages, they will promptly respond कि नहीं नहीं इसमें तो कुछ गड़बड़ी है. So that is where actually it helps a lot. So, but yes, what we find is that this color coding can be a bit different. Like for those patients who need referral, that can be in green actually, red actually. And the cutoff as per WHO has been 6/12, but in the recent myopia meet in January at RP Center, it was like unanimously decided that for Indian setting, it should be reduced to 6/9. That should be the threshold for screening for myopia, especially in children. So this one is for presbyopia. The patient himself does it, just makes the marks whichever the e-tumbling side is, and you get a results for near vision also for both the eyes. And the patient knows, okay, okay, now definitely I need a glasses. Like it's very difficult to again counsel, especially female patients, nothing negative about it, but just they are like skeptical about using glasses, especially in the rural settings. But once they see these numbers, they definitely shift to it. Now, already 3 studies have already been done to validate this app, mainly in the Center for Eye Research in Australia, and which is a WHO collaborative center for prevention of blindness. So they came up with a very wonderful sensitivity and specificity, around about 80-90%. So that is good enough for a screening app. Okay, so that decreases a lot of load. And as I said, we also simultaneously have been doing with the app and with the traditional mode, and like we'll be coming up with the results once the study gets completed. It's a 1-year study that we have been doing. So advantages we already mentioned, especially educating the parents, it becomes very easy with these percentages and graphs. And since the patient is actually participating and engaging actively, it becomes very good activity. So now this is like one like off the smart thing, but yes, this again we found very useful for myopia screening in children. So we place a Snellen, we placed this is like one of the schools where we screen 100 children on a day. So we placed the Snellens along with the WHO Eyes app. We also placed the Snellens just beside the blackboard, and we have asked the school to just let it remain there. So whenever the child is like on the last bench, so this is the methodology that we ask the teachers to follow. So student coming on the last bench should read it, and if he is unable to see the 6/9 line, he should be reporting it. Or self-reporting can also be done by the children actually. So if they are unable to say that, they will definitely promptly report. And since it's a rotation-wise sitting, so all the students actually get screened within a month. So that can actually be done, and that can come with a very good early screening of myopia for the children. So take-home message is vision screening and documentation can be smart. Smart by smart, we already showed what we mean by that smart thing, and WHO eyes, and but similar apps can be like modified for the Indian settings, and that would be a boon. So like, and HMIS compliant apps. So that is one thing. HMIS compliant apps are required for Indian eye settings. Make in India apps will do wonders for us, but there are hurdles. Again, as Sir said, initial setup cost is a bit of an issue, but in this actually it's not a cost at all as far as screening is concerned. The app part, the HMIS app part, that may be a bit costly. Being in government setup, like we do not have to worry about it, but yes, some initial investment definitely it will be entailing. So training equipment, now these are like very minor things, but yeah, the major part where the hurdle lies is the last part, the cross-talking of the app and integration. So what we showed is the documentation on a HMIS and documentation of vision. But these images to be incorporated in the HMIS, that is still the gray zone that has to be cracked, and that is what we have been trying to do with the CDAC team. So that is one thing, the gray zone that once it gets resolved, so actually in the HMIS you will be getting all those images incorporated in the app itself. Ki iska itna percentage loss and all those. So presently what we are doing is we are storing those screenshots and then educating the patients, children and patients regarding that. So that is, I think, the main hurdle for this implementation on a wider scale. So yes, I definitely acknowledge it, this presentation to my patients, colleagues, residents, sir, my MBBS and nursing students, and my nursing officers who actually cooperated a lot in making these presentations. So thank you all. And next I invite Dr. Mrinal for his presentation on smart screening for cataract. It's freely on Play Store, ma'am, so you can download it, and it's like very easy. It makes things very easy actually.
Good morning, delegates and faculties. Today I am going to talk about cataract screening through technology, torch and DDO. First of all, as our institute lies in the most underdeveloped part of Jharkhand, that is Santhal Pragna area, a tribal belt divided in basic health facilities and awareness. Observing these challenges and cope up with this, our department has decided to train our nursing officers, undergraduate students, nursing students, optometrist, ophthalmic assistant, peripheral health workers for community screening of patients with low vision through basic equipments. Screened patients are referred to our department for further evaluation and management. These are some basic equipments, such as we use smartphone, direct ophthalmoscope, Pelli-Robson chart, torchlight, and digital camera. First of all, torchlight. Torchlight examination is one of the basic traditional technique for external eye examination. With the help of torchlight, we can observe lenticular changes in eye. Basically, for screening cataract, we observe two findings: color of pupil and iris shadow. In color of pupil, we can observe changes in pupil color like yellowish color, blue color, black color, or amber colored. Then we will observe iris shadow. Here we are examining iris shadow. I am flushing torchlight over temporal iris and finding any eclipse sign or iris shadow over pupillary area. Here it is a case of mature cataract. We can see here cortex is also opacified, so there is no clear space, so there is no iris shadow present here. But when we observe this video, when we observe this video, we can clearly observe that this patient is suffering from immature cataract. There is clear cortex, so eclipse sign, that is iris shadow, is forming over nucleus. In next slide, I am talking about digital camera. Advanced equipments have some limitations, including expensive price and special training needed. It will be a problem for rural setups which has limited number of both ophthalmologists and basic health facilities. This technique supports the use of low cost and easy to use equipment such as digital camera. In first picture, there is normal red glow, but when we observe second picture, there is in left eye we are observing absent or abnormal red glow. The causes of abnormal red glow may be congenital cataract, PHPB, retinoblastoma, retinopathy of prematurity, etc. Next, we are discussing about distinct direct ophthalmoscopy. Used to get preliminary idea about the status of ocular media and fundus. This should be done routinely before doing a direct ophthalmoscopy. Equipment needed: self-illuminated direct ophthalmoscope. Procedure should be performed in semi-dark room. The ophthalmoscope should be kept at a distance of 20 to 25 centimeter from the patient's eye. Normally, a red reflex is seen at the papillary area. Here, our nursing students is performing distant direct ophthalmoscopy at a distance of 25 centimeter. We will follow RRR and LLL rule. If we are observing patient's right eye, we have to observe through our right eye and hold ophthalmoscope in our right hand. Same thing applies for left eye. In this video, we are seeing a shadow against red fundal glow. This shadow is strongly suggestive of any opacity, which may be cataractus or through other things like vitreous hemorrhage, corneal opacity, etc. Pelli-Robson contrast sensitivity test. Contrast sensitivity testing is similar to visual acuity testing. The goal of this test is to find out how easy it is for you to separate an object from its background. Cataracts can decrease image contrast. This happens because the cataract can cause light scattering and glare. This is Pelli-Robson chart. Letters are arranged in triplet forms. When we go from upward to downward, intensity contrast decreases. In this video, our undergraduate student is performing Pelli-Robson contrast sensitivity testing. This patient is suffering from cataract, so he is able to read upper 2 or 3 lines, but he is unable to read lower lines. Tele-screening. We perform tele-screening because, as we know, that our institute lies in tribal belt, so there is very low accessibility. So we can outreach peripheral setups through tele-screening, reliability with invent of automatic artificial intelligence, there is increased reliability, it is time saving, we can perform early screening, health awareness, we can, through tele-screening we can aware people about their ocular comorbidities. With tele-screening we can timely referral is possible, disease screening, disease burden is decreased due to performing tele-screening. Further, tele-ophthalmology has the potential to become a time and labor saving method with the assistance of artificial intelligence, online electronic health record systems, smartphone apps, and cloud-based platforms are accessible portals for tele-screening. Take-home message. With mere use of basic instruments and some training, we can address vast majority of cases which are neglected and unseen due to their geographical location, poor economic background, unawareness, etc. All patients screened for cataract through outreach programs require a comprehensive eye examination to identify ocular diseases other than cataract. Provisions must be made for health awareness and strengthening basic health infrastructure. In this photograph, we have conducted a camp 2 to 3 months back in which we used our basic equipments with artificial intelligence to screen out cataract, not only cataract, but also other vision-threatening diseases like diabetic retinopathy, hypertensive retinopathy, glaucoma. So tele-screening is very useful. We conduct this type of screening in our department every 3 to 4 months interval. Thank you for your cooperation and listening. Now, lastly, I would like to call Abhishek sir to conclude our session. Thank you.
Thank you, Dr. Mrinal. That was a very good presentation, and that was actually his maiden presentation, so I congratulate him for that. So, and like one of the images that he showed was a video of through the peephole of direct ophthalmoscope performing a distant direct ophthalmoscopy in which we actually visualize that central PSC cataract. So that is one thing that he very wonderfully captured and that we can actually do. So those are the arts that we have been actually failing to transmit to our undergraduates who can actually be our workforce for all this screening thing. So that actually is a part of their curriculum as per NMC. They have to learn it. So if they are learning it, they can actually utilize it in the community whenever they are having their postings. So next talk is on the ABC of vision threatening glaucoma screening, Amsler beams confrontation. So that those are the ABC, and we have added a digital device as the ABCD of it, but mainly conforming to the rural settings and the tribal settings, ABC are the ones that are of prime importance. So no financial disclosures. Glaucoma, we already know the impact worldwide, the magnitude, the undetection rate, and the numbers are staggering, so I won't just go into the numbers. The Indian scenario definitely is more alarming, with prevalence of 2.7 to 4.3, blindness 1.2 million, and 5.5% of total blindness. And it is a leading cause of irreversible blindness. So that is one point that actually is why that we need to screen it early. We already know. So we have been conducting World Glaucoma Days and screening camps. That screening should be done. So that is the part we actually know. We know how to diagnose it. We know how to treat it. But the gray zone is the screening and the awareness part, which still is lacking as per the literature also. So awareness, as one of these reports mention, awareness is like only, so it was like very less in the Indian population, and undiagnosed glaucoma is again 90% in the Indian population. That is what data suggests. So having said that, what should be done? So traditional community-based screening, though we may not like to accept it, but yes, it has mainly largely been IOP based. So that is how we screen for glaucoma mostly. So it's only IOP we take, and okay, ठीक है, IOP बढ़ा हुआ है तो glaucoma के लिए करते हैं, नहीं बढ़ा हुआ है तो नहीं करते हैं. That is mostly in large parts. I think there is no denial. Mainly in sub centers, they definitely modify it, especially if it's a research institute, they definitely add on to those things. And some people, like if they have a trained man force, they actually go for a direct ophthalmoscopy, undilated direct ophthalmoscopy also. So those are the things, like again, not done in silos, but not overall. So that is mainly the main bane of glaucoma screening in the Indian settings. And it has already been documented, like way back in 83, that screening with tonometry does not appear to be warranted at all, not cost effective, because you end up screening and referring more patients rather than who you want to treat for it. Okay, so what is lacking is, so as I said, tonometry alone is inadequate. Visual field assessment largely lacking. Optic disc examination, yes, partially it is done. So applying those again, those methods, HMIS mobile app, on spot, so that we have already dealt with, so I won't go into the details of it, the how you capture the epidemiological data of the patient and the vision screening part. So coming straight away to the glaucoma screening part. So okay, so the ABCDs, the A stands for the app-based vision screening that we already discussed. And the second part is AMSLR. So AMSLR has actually been tried and tested, but we do not again use it. Again, it is not a very time consuming process. You won't be able to detect early glaucoma. But in Indian settings, actually, early glaucoma, if you detect, that's a wonderful thing. But at least you should be able to screen the vision threatening glaucoma, and that is what AMSLR can easily do for you. So that is our like a main take home message in these talks, that for glaucoma, for diabetic retinopathy, at least you should be able to screen the vision threatening parts. If you are unable at least to screen for the early detection, that is okay. If that can be done, that will be great. But since you have a like that shortage of ophthalmologists, retina specialists, glaucoma specialists, so at least we can cover this part. So AMSLR is something that we can do. Beams, eclipse sign in torchlight, again, which is taught to the MBBS students, they learn it very well, and that can be applied actually. And confrontation, again, same thing, which is a part of their curriculum. So vision screening we have done. Now this is like, now again, these recordings for this purpose, we haven't actually done, we have done it in our setting rather than the camps for a proper documentation of it. So AMSLR, the technique is told to the patient, and we just on a mobile, we get the proper dimensions of the AMSLR, use the photo app so that patient can actually draw कि आपको कहाँ क्या दिख रहा है, and the patient actually draws the things, as will be seen in this video. So marking the boundaries where the patient sees it, any dark spots, scotomas or wavy lines, whatever is visible, the patient can actually mark it. So yes, again, like this will be, sometimes it takes a longer time because the patient comprehension of that thing, what has to be done, may take a longer time. But eventually the patient understands what is to be done and does that. Again, in all these, we have only used our nursing officers, residents, and MBBS and nursing students, MBBS students and nursing students for documents. So this is what the patient actually drew for the marking the superior edges. Inferior, I think we did not capture. Now, these are the MBBS students for whom actually we have done a video-based clinical examination teaching. So they are performing the eclipse sign. Because angle closure glaucoma, if it is not an acute congestive glaucoma, is often missed. You do not actually look for it. You look only for IOP, especially in the screen setting, community settings. So at least you can do, obviously, if you have a handheld slit lamp, you can do a Van Erichs. If you have a Perkins, you can do a proper AT. But in our settings, we already know there are limitations. So at least you can do this thing for eclipse sign. And if you see like a very shallow, as I said, vision threatening, which can convert to angle closure attack. So those patients you can definitely screen. Confrontation, again, now this is like very reliable. So we have been able to publish one like biomedical student who performed it for a patient who came to the like a community OPD, third year student. She was able to pick up based on confrontation. The patient was actually complaining, ठीक है मुझे थोड़ा बहुत side का कम दिख रहा है. She documented it, and it was like a pituitary tumor, which is actually published. So expanding the, so that was like mainly for the tribal settings and very low resource settings where we can apply those ABCs. Extending it to the Ds apart from app and AMSA, as I said, if you have resources, you have the funds, portable Perkins, that nothing can replace an applanation. Like till date, we are mainly doing whatever we are doing is on the basis of Shios mainly. But yes, one more thing on the D part is we can add a digital tonometry again to at least detect those higher IOPs. And digital screening is what is left that we'll be talking about. So one part has already been covered, like using the smartphone and a 90D, you can actually visualize the disc very well, and that can be like screened real time. So this is for the same instrument that was used for diabetic retinopathy. We used it just in our World Glaucoma Week celebration, and we were able to like pick up those findings. So this is again a very easy app. You just undilated fundus, so you can have those photographs. So patient compliance actually increases a lot. So there is no dilatation involved. The patients actually say कि ठीक है हमारी screening कर दो. Once you say कि dilate करेंगे 1 घंटा बैठना पड़ेगा, blurring होगी. So they say okay मेरे आँख में तो कुछ है ही नहीं, क्यों इतना डरा रहे हो? So that happens a lot actually. ठीक है. So once you do it with an undilated fundus, apart from the fundus, you get a report. So that report again is a very reliable one. The studies have been done, published in the Eye Journal, and with a good sensitivity of around about 85 to 90% sensitivity and specificity for these devices. Okay, so they actually give you the referable glaucoma. So yes, this once it comes in those fonts, orange, red, the patient knows, okay, ठीक है, अब मुझे तो दिखाना है, something is wrong. Again, as I said, percentages and figures actually help to convey more impactfully rather than just mentioning कि आपका IOP बढ़ा or you have some problem with it. So that was the process. We just select the clear images and it will self-generate a report. So the AI-based reporting is like good. And these instruments, actually the prices have come down reasonably. So I think this can be like a very good tool for future proper glaucoma screening methodology on a national scale. So these again, as I said, are performed by our junior resident, MBBS students and our senior resident. And this is something actually I came across yesterday in one of the stalls. So as I said, for the HMI's documentation, we can use the QR. So we can actually use the QR also for the awareness part. So this is like one scan QR. I tried to scan it, and this is what actually comes up. So it actually, once the patient scans it, you get everything regarding awareness regarding. So this slide actually put up yesterday when I visited the stall. So the QR based thing, not only for epidemiological data, but for patient awareness, that can have a very good impact. And like people love to scan QRs, even children love to do that. We know that. So I think that can be a wonderful thing. So take home message will be enable. So what we need to do is have a proper and a vast workforce capacity building for proper screening. So where can we get them from is mainly from the MBBS students and nursing students who can be easily taught those easy methods which are in their curriculum. So if they can be trained, then definitely we can have a very good workforce, at least for the screening of vision threatening glaucoma. That is what our goal is for these talks. Okay? So it can be performed reliably by non-ophthalmic healthcare force, as we already told. And yes, so telescreening and awareness can be bettered. Thank you. So that concludes actually our talk. This talk on smart screening. If there are any questions, we can take up that. Like ma'am asked about the availability of that is freely available with all the the advices and how to perform it. That can be actually be implemented. If there are any other questions, please. Any concluding remarks from Samantha sir, please?
Thank you, Professor Onkar. It's really a very informative instruction course and very much practical to implement in each and every corner of the country. I'd like to request each and every participant to disperse these ideas to their fellow faculty members as well as all the hospitals and community eye health personnel. by the term community eye health personnel nowadays, we like to make the broad term. The state program officers in ophthalmology, each and every state is there. There are so many corporate hospitals, private hospitals, voluntary eye hospitals under NGO. You can disperse these ideas, and our government sector. What I have told at the very beginning of my talk, and what Professor Onkar has elaborated all the way, to do any work, we must have got need assessment study. And this smart technology is the best way for the need assessment. Then and then we can proceed for further planning and implementation. Thank you very much.
Thank you, sir. So we conclude the session. Group photo, sir.
Yes. Group photo. बहुत अच्छा अब लोग मेंबर बन गया एडवाइजर आज हाँ सब दोनों ही मेंबर बन गया हुआ